Well, thanks for letting me talk a little bit about my role with the liver transplant team. I've been working with the transplant team as a consultant for about 20 some years. And I primarily see the pre-liver transplant patients that are both inpatient and those that come for an outpatient eval. And I have a colleague, Christina Lightborn, that I work with, and she sees some of the outpatient pre-liver transplant, and she follows transplant patients post. So she's an integral part of this as well. So just a quick overview on what we'll be talking about in this brief presentation, just some basic statistics for you, and a little bit of education about what the evaluation process is like from the behavioral health standpoint, and what happens once patients make it, quote, on the list, which is always the goal for them. And then what about relapse? Can we predict who relapses, when, and why they relapse? And just some conclusions about that. Basic stats. The first liver transplant was done in 1963 at the University of Colorado by Dr. Starzl. So it really has not been around as long as you'd think. The UW has been doing transplants, I'm sorry, I don't have the exact date, but since the late 80s, I believe. In 2018, there were 7,526 liver transplants done in the US. And at UW Hospital, there were 112 done. In 2017, 125, and 2016, 105. So it varies some, but not as much as you would expect. These liver transplants include both donor transplants as well as living donor evals, where someone donates a part of their liver, the lobe of their liver. So that includes both numbers. The median wait time at the UW Hospital for a liver is approximately 10.5 months. The wait time varies depending on your blood type and a number of other factors. It's mostly driven once you get on the list by your MELD score, which is just a combination of labs and basically how sick are you and your wait time. There's a lot of great statistics down there on the corner there, those two resources. If you want to get all into stats, have fun and go there. So here at the UW, taking a look at just the diagnosis for alcoholic liver disease and alcoholic hepatitis. Out of the 112 liver transplants done at UW in 2018, 44 of those were done for those two diagnoses, or 39%. In 2017, 46 out of the 125 were done for those two diagnoses, or 37%. And in 2016, it was 45 out of the 105, so 43%. I think the other piece of information that I wish I would have got for you that I didn't, so I will apologize, is it would have been interesting, I think, to look at some of the statistics like back from maybe 2005 to 2010, if we could have looked at those two diagnoses and then added Hep C. Because the numbers would have been closer, anecdotally, I think it would have been closer to like 50% of all the liver transplants could have been correlated back to alcohol or other substances. Now, of course, Hep C is so well treated with medication, people aren't getting transplanted for Hep C anymore. They're getting cured via medication, which is great. But so at one point, UW transplant program, it was closer to about 50%. So the main thing we want to look at too is we know we're transplanting upper 30% of the folks for alcohol-related liver disease. So what are we looking at the relapse rates? So these relapse rates are reported via self-report from the patient to either the physician or the nurse transplant coordinator or they're found simply through urine or blood tests, ethyl glucopositive path. So in 2018, 8 of those 44 patients that were transplanted for that diagnosis relapsed, or about 18%. 7 of those patients relapsed with alcohol, and 1 relapsed with alcohol and opiates. 4 people agreed to seek outside help, and 1 agreed to be on Suboxone. In 2017, 5 patients out of the 46 relapsed with alcohol, or 11%, and only 1 of those 5 agreed to seek help. In 2016, 15 patients out of the 45 relapsed with alcohol, 1 relapsed with cocaine and heroin, about 33%, and 3 sought help, and 1 started Suboxone. So it's quite a variance. You know, from 2016, we had 33% relapse, and in 2017, only 11%. Again, we don't know exactly why we had such a change in the statistic. Anecdotally, of course, we have all kinds of reasons why. Some of it was the addition of Christina Lightbourne's position. So we had another behavioral health person that was being consistent, talking with patients both in clinic and out of clinic, calling folks, getting people connected to outpatient treatment, being another support system. So her position, I think, certainly helped to decrease the risk of relapse. Still, when you look at those rates, compared to the number of people that relapse after a residential treatment in the first year, it's not so bad. Pretty good. So getting to the actual liver evaluation, who, what, when, why, and how. So how do people actually get to the point of needing a liver evaluation, and how do they get to UW transplant program? They can come in any number of ways. Some patients refer themselves there. Most are referred by their primary care doc or a local GI specialist. Other centers may refer. Some centers may deny a patient and recommend they come to UW. We are the center of excellence for some insurance companies. So patients can come from any way. They may just end up in the ED, and that's the first they're aware of their liver disease, so they come in directly from the emergency department. Why do they come? Patients come at any level of liver disease. They may come in fulminant hepatic failure, or they may come from their primary care doctor saying, I think it's way too early, but let's start the process. That leads into the when. Some people come and they're intubated and they have no idea that they're in fulminant failure and they're critical. Other people come and they're told, nope, you're way too healthy to list. You'll probably never need a liver transplantation. So they leave feeling very happy at the end of their eval. So people come in needing evaluation. It can be done in inpatient, or it can be done during a 2-day outpatient eval. It includes lots of testing, procedures, education, and evaluation. They'll meet with hepatologists, surgeons, nurse transplant coordinators, social workers, dietitians, financial, and when indicated, they'll meet with behavioral health therapists such as myself. The actual assessment that we do for folks is impacted by a number of factors. It's impacted whether they're an inpatient at the time of the evaluation or they're an outpatient. Both of those have the pros and cons. Inpatient folks tend to be sicker, but they also tend to be kind of a captive audience. They're often ready to talk. They're expecting to talk to people. As an outpatient, they're meeting 6 or 7 people all day long, so they're giving their history over and over and over. When they come as an outpatient, they're expected to bring support people with them. When they're in the hospital, they may or may not have a support person with them. Sometimes when they're in inpatient and they're in the ICU, I may not be able to interview them at all, so I have to gather information from a chart review or from talking with family. And again, family may or may not know the extent of the patient's substance use. There's always a level of urgency if they're in the ICU. Sometimes they may not be expected to live more than a couple of days without transplantation. So there's a sense of urgency to get as much as you can information regarding a patient's history from chart review and family. What the assessment actually contains is certainly demographics. You want the basics, kind of the where do they live, what's the story behind who they are. You want to get as much substance use history based on the DSM as you can, including all substance use, not just alcohol or IV use. Do they have any mental health history? Do they have a history of abuse or trauma? Do they have a history of AODA or mental health treatment? Are there currently safety concerns? Is there family history of substance use or mental health disorders? And what have the medical consequences and the patient's level of awareness? The medical consequences, it seems like a given. They should know, yeah, they're here for a liver eval, that they know that their liver has been impacted by their alcohol use. I always start out the eval asking them, what's your liver disease from? I think it's important to find out what their awareness is, and many times I will get the answer, they don't really know yet, where you read in the chart it's been explained over and over that it's from alcohol. Or I may get the answer, I drank too much. It really can give you the starting point for my understanding of what the patient's level of awareness is. So this assessment really is not anything unique to any other behavioral health assessment that you're doing. So what are the recommendations that are most commonly made after an assessment? Clearly abstinence. And we make the recommendation of abstinence from all substances, not just the alcohol. We are often challenged with the abstinence requirement of marijuana. We certainly recommend abstinence from marijuana if they have a history of any addiction. What do we do? What kind of referral do we make? It somewhat depends on how long the patient's been abstinent. Kind of the rule of thumb with the transplant coordinators is if anyone has used alcohol or has a history of an alcohol use disorder within the last 3 years, they want them to be seen by a behavioral health therapist such as myself or Christina. So if someone's been sober for 2.5 years, I'm probably not going to send them back to any kind of outpatient treatment if I feel like they really have an understanding of their alcohol use disorder and they've been able to maintain abstinence. We may look at what are they doing, what's their current support network. Some people go to AA, some people like Smart Recovery, some people don't like peer support at all. Some people need referral to mental health counseling. They have anxiety or depression, bipolar. We also encourage any kind of alternative support systems, such as mindfulness, yoga. There are lots of good apps out there. We look at friends. And often we will make the recommendation to the team that they do random urine and blood screening, looking for utilizing the ethyl groups in the path. So if someone makes it to the list, and making it to the list means that they have, their case has been presented. We present patients once a week in the liver selection committee meeting, which I attend weekly. Everyone that has had any input in that patient's evaluation provides feedback to the team regarding their piece of the patient's workup. So if everything fits and they make it to the list, what do we do then? This is where there's ongoing monitoring of the patient's abstinence. If they were referred to some counseling, there's communication with the patient as well as the local provider, because most of our patients are not from the Madison area. We always have continued contact with the patient's support people, and again, the random screens. The ethyl group detects alcohol for up to 80 hours, but the PEth detects heavy drinking within the previous 3 to 4 weeks. Takes about 4 days to get back though, so that test does take a while, and it's expensive. So what about relapsing after liver transplant? Are there predictable factors? Yes and no. There's been a lot of literature written about this. Some written by Dr. Michael Lucy, who is a hepatologist with the UW. You can be lost in the research for days regarding this. Christina and I have done a lot of looking to try to come up with some kind of tool that she and I can use to look at, can we come up with our own relapse predicting screener. This article that's cited here took a look at 51 articles and tried to lump the variables. They came up with these 5 broad categories. The first is the ever popular 6-month rule. So when I started working with the transplant program, it was a hard rule that patients had to be abstinent for 6 months. That is still the rule for many, many transplant centers across the country. Some transplant centers will not even evaluate patients until they have been abstinent for 6 months. That is not the case at UW for any number of reasons. Each case is looked at individually. So Dr. Lucy will say that the 6-month rule is arbitrary. However, the research does show that the longer the period of abstinence, the lower the relapse risk. The second variable, or the risk factor category, is just looking at duration of use. Number of drinks per day, the higher the number, the family history of alcohol use disorder, and the earlier someone went to treatment, the higher the risk of relapse. Social factors, of course, common sense. If they have a lack of stable relationships, lack of support, if they're continuing to engage in social activities that are alcohol related, they're still going down to the same bar, but now they're drinking soda. All those things that indicate that awareness really hasn't sunk in or behaviors haven't changed. The comorbidity of any kind of mental health disorder is also a risk factor. So again, we screen for those mental health things and assist people in getting some counseling for that. And then just the final category is really looking at just compliance in general and motivational characteristics. Have they accepted the alcohol use diagnosis? How has their compliance been in general with follow-up, not just with AODA counseling, but in general with medical care? So in conclusion, liver transplant saves lives. Treatment for AODA issues saves life. Liver transplantation is not treatment for an alcohol use disorder. We emphasize over and over and over to patients as well as to the staff. These are 2 different diseases that need 2 different treatments. Liver transplantation does not ensure that someone will not drink again. They need to have the disease of their alcohol use disorder treated in order to maintain abstinence, just the same as they need to have their liver transplantation in order to effectively transplant and maintain their healthy life.
Thanks a lot.
Yeah, questions?
Yeah, any questions or discussion?
This is Sheila. Just one thing, this last slide. Absolutely. Because I can recall over the years, people having this concept, well, after going through a liver transplant, they certainly understand why they can't drink now. And it's like, they didn't have a brain transplant, they had a liver transplant. So indeed, very, very important.
Yeah. I think sometimes that's a hard thing for
Yes.
some transplant staff to understand, because
And
it is
families. And families.
Yeah, and seeing the transplantation as the gift of life, which it certainly is, but that's not treating the addiction. And I believe people that are pre-liver transplant, and I believe them wholeheartedly when they say, I will never drink again. I would never do that to the donor family. And I believe them at that time. That is what they believe. But it's an addiction, so we still have to treat the alcohol use disorder.
Right. Because that neurobiology is there, and then some of the medications.
Yeah.
seeing post-transplant seem to sometimes make things more difficult unless they've got a solid recovery.
Exactly.
So yeah, so I appreciate that last slide a lot. Thanks.
Mhm.
Yeah, I also noticed, and I've noticed sort of in practice at UW Hospital, in years past, it seemed like really the indication around transplant was pretty heavily, if not near exclusively, for cirrhosis, but where we're starting to see more consideration for alcoholic hepatitis. Is that true, or are you seeing that increase more, or is that?
I think we are seeing that more, and I think on the inpatient unit, we're seeing people come in with acute ALCAP, and then they'll do a quick trial of the steroids while they're inpatient, and if they don't respond to the steroids, they're quickly then get targeted toward transplant.
Okay,
so they're non-responders to the steroid.
And on the distant end, the steroids seems to have made a huge difference in what we see on cases. People seem to progress fairly quickly to needing transplant. And now we've seen a number of people, as you say, turn around and not head down that direction. So that's been very interesting over the decades watching that change.
Other issue I imagine crops up, I mean, this being a referral center, is that a lot of people may come from areas where they may not have all the resources that they need. And I wonder sort of how that discussion goes. Say if someone's from a rural area where they may not have access to the resources the team thinks of as optimal. Like, what does that conversation look like when you have someone in that kind of situation?
Yeah, I think that does come up a lot, and it ends up to not just being the AODA resources, but it's not unusual where I'm asking someone to travel, 30, 40 miles to go to an outpatient counseling, and then social work is also asking them to, develop a good support system when they really have no family in the area. They've kind of alienated themselves from friends, so they've got no one that can come in and stay with them. They've got an uncle that lives in California. It's really hard sometimes for people to pull together what is a necessary support team post-transplant. So it takes a lot of work on a lot of levels. So even though medically they may be ready for transplant, the psychosocial stuff is really important and takes a lot of time to work on.
Yeah, I mean, and there's a lot of work to do is sort of leading up to around the time of and after a transplant. Are there resources, individuals as part of the transplant program that can do some of that outreach, if not just by phone? And
I think there are. The pre-transplant social workers do a lot of that work, helping with patients, and there are systems in place. With home health, they use the same types of resources that any outpatient would use, but patients do fundraising. The medications are so expensive, and if you have a 20% copay with transplant, you're going to be bankrupt. So there's a lot of offshoots. Pharmaceutical companies donating some meds, and the social workers are amazingly great at problem solving. I give a lot of kudos to them.
Oh, the other thing that I was kind of wondering about, you mentioned sort of the assessment around, eligibility involved. So are there pretty strict guidelines around what that needs to look like? And are those at an institutional level or some level beyond that? Or?
So the AODA assessment really just needs to follow JACO regulations. There's not additional requirements from the transplant. We just need it to be consistent with every patient. The social workers have started to use a CSAC score, which is, I can't remember what it stands for, but it is a scoring tool that is used nationally. So they get an actual number from 0 to, I believe it's 120, which helps people fall into a category of risk, which counts all kinds of psychosocial issues. So you may fall into a category that says that you're a poor compliance. So there will be strict things they have to do to increase their score or lower their score.